So let's talk about functional capacity evaluations. A functional capacity evaluation, also known as an FCE, is a formal evaluation done most often near the end of a rehabilitation process. Numerous training and FCE certification programs exist for rehab professionals, each with their own parameters for administering the evaluation. This has resulted in a lack of standardization across the industry, with some evaluations being as short as 2 hours to as long as a full day or even 2 days in length. The usual FCE averages around 4 hours in length. An FCE is defined as a compilation of physical standardized and non-standardized tools to evaluate the client's strength, endurance, speed, and flexibility. FCEs are designed to answer specific referral source questions, such as returning to a specific job, or they could be used for general employment planning. An FCE is designed to have utility and is practical while maintaining validity, reliability, and safety. An FCE tests for the client's provision of full effort. The length of these assessments allow for observation of consistency over time and between different objective tests within the FCE. There are also effort testing components built into each specific objective test. FCEs usually test if the client is reliable in their reports of pain and disability. This is done by comparing objective performance to reported ability during the interview and compared to their ratings on validity of self-report measures. There's also a type of FCE called a cognitive FCE, which contains the same physical testing as an irregular FCE, but also includes standardized cognitive assessment, non-standardized assessment, and simulation activity to promote the observation of cognitive, physical, behavioral, and psychosocial function. Of note, there's limited providers who offer cognitive FCEs. The concept of a short functional capacity evaluation has been researched, showing no statistically significant difference in administration or clinical outcomes compared to a full FCE. A short FCE's protocols are customized to each body area, such as the trunk, the lower extremity, or the upper extremity. A short FCE is more efficient by limiting the protocol to prognostic testing only. Considering the nature of a more efficiently administered protocol, short FCEs have the potential to be given by the treating rehabilitation provider. Incorporating job-specific testing as part of the course of the rehabilitation process allows for a more effective rehabilitation plan and will better guide OC health providers, physicians, the employer, and the worker. Functional testing designed around job demands will promote getting clients back to work sooner and decrease the frequency at which a full FCE is needed. Job-specific functional testing is customized, which limits the potential for standardization and limits the potential for support in the literature. One example in the research, though, is a job-specific protocol that was designed for nurses. On-site observation allowed for identifying positioning and activities, durations, and frequencies, as well as required load intensity to create a testing protocol. This protocol was more valid and efficient compared to testing protocols that were not job-specific. So as we look at a conceptual framework for selecting functional performance testing, we want to match the worker's condition to what testing we're doing. So is it upper extremity? Is it lower extremity? We want to identify activities that are restricted by the medical condition based on our knowledge of the occupational professional. So in other words, what we know about the job and task demands, and also information retrieved from the worker, them describing what their functional deficits are. And we can select functional tests from a full FCE related to the restricted activities identified in step 2. We want to also select other relevant functional performance tests as needed to match the work demands. This is directly from the CPT. So physical therapists should use valid and reliable physical performance tests throughout the episode of care to measure the individual's workability and to inform treatment and prognosis, which may include a full functional capacity evaluation, a short form FCE, job-specific functional testing, or other performance measures. As we research what demands a job has, there's a few resources that we have to do that with. There's ONET, which is the Department of Labor's present resource for job descriptions, which you can see the link. We have a link up on the slide for you. And there's also the Occupational Requirements Survey, which has functional job descriptions. This slide is directly from the CPT. We'll let you look at it at your own pace, but this has the information that I just shared with you in the past few slides. So we look at cognitive examination. There's numerous types of injuries or diagnoses that can result in cognitive deficits that can impact workability. Oftentimes, these cognitive issues are very apparent, such that they limit the patient's ADLs, home management performance, and ability to effectively interact with the provider during a healthcare visit. Other times, cognitive deficits are more subtle, such that the person appears to have no limitations at home, but there is unforeseen cognitive limitations upon return to work. Knowing the cognitive demand of the job is essential to design a work-specific evaluation process. Information can be accessed through an employer job description, general job description, like can be accessed on ONET, and a direct description from the client. It is ideal to use multiple sources for a more accurate representation of the job. A cognitive screening tool, such as the Montreal Cognitive Assessment, is a good starting point for collecting objective data and highlight deficit areas that need to be tested more thoroughly. It must be noted that screening tools may not be sensitive to higher level cognitive deficits. Further testing may be warranted despite a normal screening score. Detailed reports of deficit during the interview and observations can also be used as a guide to what should be tested in more depth. Numerous standardized cognitive assessment tools exist to assess specific cognitive areas in more detail. Examples of this include the Test of Everyday Attention and the Rivermead Behavioral Memory Test version 3. If deficits were identified with cognitive screening, using an objective test designed to assess the specific deficit area can be used to gather more in-depth information and guide future treatment. Cognitive testing tools that look at specific cognitive areas, such as memory, are beneficial, but a worker with a mild cognitive impairment may still perform well on these types of tests. It is important to incorporate functional assessment into the evaluation process to help capture the worker's ability to regulate all isolated areas of cognitive performance together. Examples of this style of assessment tool include the doll chair assembly test or the complex task performance assessment. There are a few functional standardized assessments available, So at times, the rehab professional may have to create a custom work simulation task to further challenge executive function. Workers with neurologic-related injuries or medical conditions may have mild cognitive or visual deficits that are not immediately evident to the medical community, yet may have significant impact on sustaining or returning to work. Workers may be involved in rehabilitation for other non-cognitive related issues. Rehabilitation professionals need to maintain a holistic view of the patient as returning to work is considered. The patient's insight into cognitive or visual deficit areas may be limited because they have not challenged these abilities to the extent they will be challenged at work. Asking detailed, open-ended questions is essential to help gather more information to know if cognitive or visual rehabilitation is needed. Alternate rehab providers may need to be involved in care, considering not all rehab professionals provide these specialized services. Self-report measures such as the behavioral rating of executive function, adult version, the post-concussion symptom scale, and the work disability functional ability measure are especially helpful with clients with insight deficits and complement the interview process. As we look at visual examination, asking the question, have you had any changes in vision, at some point in the examination process is important to help determine if further in-depth examination is necessary. The initial interview, physical deficits testing, and cognitive screening may also raise some questions to visual deficits and indicate need for more in-depth examination. If visual deficits are reported or evident, in-depth assessment of visual performance areas is necessary to create an effective rehab and return to work plan. This should be performed by a healthcare professional specialized in vision. A rehabilitation provider who is experienced in vision may be sufficient, but at times, optometry or ophthalmology may need to also provide care. When we look at optometry, they assess for basic eye health, they test acuity, and they provide glasses prescriptions. Ophthalmologists are physicians that can diagnose and treat a wider range of eye diseases than optometry can. Some ophthalmologists specialize in neurologic-related eye conditions. An OT or PT specialized in visual rehabilitation can assess and treat the eye-brain connection. Examples of areas that are addressed include tracking, saccades, convergence and divergence, strabismus, peripheral vision availability, and the ability to process both peripheral and central vision at the same time.